So, good afternoon, everyone. Uh, Department of Medicine, Unit 3 is going to present a clinical combined round today, and we are going to present case obvious but mysterious. It's an interesting case, and we are following up this case from August 2021, and last follow up was done in Jan 20, 2022. So, we have team of doctors here who are going to present this case. I'll invite first to Karan. Please come.
Good afternoon, respected faculties and my dear colleagues. Today I am presenting the interesting case that was present to us in July 2021. Uh, the patient is a 51-year-old male businessman, resident of Gurgaon, Haryana, presented to us in the month of July with the chief complaints of fever for 2 months and yellowish discoloration of eyes for 1.5 months. Fever was continuous. It was initially low grade, then gradually rose to 102 degree Fahrenheit on presentation. It was associated with chills without rigors. There was no diurnal variation, and it was relieved by antipyretics. It was associated with yellowish discoloration of eyes for 1.5 months, which was gradually progressive and was associated with dark color urine. There was no history of nausea, vomiting, pain, abdomen, pruritus, or pale color stools. These were associated with decreased appetite, and there was a history of weight loss of around 3 kg over 2 months. There was no history suggestive of any cardiovascular, respiratory, or central nervous system involvement. There was no history of photosensitivity rash or any other rheumatological symptoms. There was no past or family history of TB. There was no past history of blood transfusion. No history of animal bite or pets in the family. Patient was evaluated in the outside hospital from May 2021 and has received the course of antibiotics during this time with no symptomatic improvement. The patient suffered from mild COVID-19 infection in May 2020 and was recovered fully with no residual symptoms. Patient is a known case of type 2 diabetes mellitus since 2016, which is well controlled on oral hypoglycemic agents. Patient has normal sleep pattern, normal bowel bladder habits. There is no history of illicit or over-the-counter drug abuse. There is no history of alcohol intake or chewing tobacco. So summarizing symptoms till now, we have a case of fever for 2 months with jaundice for 1.5 months with associated with weight loss and anorexia. On physical examination, patient was febrile with tachycardia, teres was present, and there was no pallor, clubbing, cyanosis, lymphadenopathy, or pedal edema at presentation. Uh, there was no focal signs or was suggestive of any focal or system involvement. There was no skin rash or erythema nodosum. Oral cavity examination was normal. There was no feature suggestive of splinter, hemorrhage, Janeway's lesions, or osseous nodes. In eye examination was normal, and there was no uveitis, and there were fundus examination was also normal. On systemic examination, liver was palpable up to 2 centimeter below the right subcostal margin, and spleen was not palpable. Chest, respiratory, cardiovascular, and central nervous examination was unremarkable and normal. So, summarizing history and physical examination, we have a case of fever with progressive jaundice, with weight loss, anorexia, and hepatomegaly. So, thinking on the line of this, the various causes of fever with hepatomegaly can be fall into infectious, infiltrative, and inflammatory. Among infectious causes, our top differentials were tuberculosis and histoplasmosis. Among inflammatory, we thought of malignancy like lymphoma, and among inflammatory disorders, the autoimmune hepatitis were our first differential. So, patient was evaluated during these 2 months outside, which showed mild increased total bilirubin, that is 1.7, with direct fraction of 1.1, along with raised ALP, that is 543, and raised inflammatory markers like CRP and ferritin. Monto test done outside showed 8 in duration, and other investigation done for common infectious disease were negative and didn't yield any diagnosis. These are the various radiological investigation done for the patient during this time. Ultrasound abdomen, HRCT chest were done in May, and CCT chest abdomen and was done in June, and PET scan was done 20 days before coming on 3rd July 2021. Now I would like to invite Dr. Palak to throw some light on the CT scan images of the patients.
Good afternoon, everyone. I am Dr. Palagat, Senior Resident from the Department of Radio Diagnosis. I'll be presenting the outside CECT scan of the patient done on 3rd of June 2021. In these axial contrast images, we can see there is no focal lesion seen within the liver or the spleen, and there are no significant lymphadenopathy seen in the porta hepatis or in the retroperitoneum. Coming to the coronal reformats, we can there is no appreciable hepatomegaly or splenomegaly in the given sections, and as calculated by the scale given, and there were no significant lymph nodes or any other lesion. In the axial contrast enhanced chest scans and the mediastinal window, we can see there is no significant mediastinal lymphadenopathy, and the vessels appear normal. And in the coming to the lung window, we can see there are no perilymphatic or central lobular nodules or no consolidation. So concluding, the CECT chest scan done outside on 3rd of June was normal.
Thank you, ma'am. Now I would like to call upon stage Dr. Sneha to interpret the PET scan images of the patient done on 3rd July.
Good afternoon, everyone. Here we can see the PET scan images of this patient done outside in July 2021. On the top left corner grid, we can see the maximum intensity projection image. On the right-hand side, in both up and the down lower grid, we can see the fuse PET CT image, and the left side bottom grid, we can see the axial CT image of the patient. In the maximum intensity projection image, we can see no abnormal focus of FDG uptake in the study. And in the fused PET CT images, we can see no abnormal FDG uptake in the liver, spleen, or the retroperitoneum. Uh, uh, and the CT image also is normal. So our final impression was that there's no evidence of any abnormal metabolic activity to suggest any infective, inflammatory, or malignant pathology in the study.
Thank you, ma'am. Now, on the basis of history, physical examination, and the investigation, till now, we have a case of fever with progressive jaundice, with weight loss, hepatomegaly, with raised liver enzyme, the ALP more than AST and ALT, and raised inflammatory markers. CCT, chest, abdomen, and FDG PET were non-contributory. So, on the basis of this, we thought of granulomatous hepatitis as the cause of this illness. And various causes for granulomatous hepatitis can be divided into infectious, inflammatory, neoplastic, and drugs. Among these, our top differentials were extrapulmonary tuberculosis, chronic hepatitis, autoimmune associated or EBV, leishmaniasis, histoplasmosis, lymphoma, or sarcoidosis. So, patient was evaluated after admission in our AIIMS, which showed the total bilirubin to be 6.7 with direct fraction of 5.2, along with markedly raised ALP, that is 1268, and raised inflammatory markers like LDH, ferritin, and GGT was also raised at the time of presentation. We did 24-hour urinary calcium, which was raised in the patient, and other investigations were unremarkable. The other finding which is shown in the patient is raised age level, which were elevated, that is 143 units per liter. So, after ruling out the various causes by appropriate investigations, our top three differentials were extrapulmonary tuberculosis, sarcoidosis, and lymphoma. So, to rule out among these, the decision to do percutaneous liver biopsy was taken, and patient had undergone percutaneous liver biopsy during the hospital course. I would like to invite Dr. Rohan from pathology to discuss the slides.
So this was a multiple course of liver biopsy which we received. So here we can see that there is a mild lobular disarray. That means that the portal tract are not dispersed in regular intervals in peace. So here we can see that there are no regular portal tracts in these cores. So coming to the high power, we can see a portal tract, portal area here, which shows moderate inflammatory infiltrate, which is composed of lymphocytes, histiocytes, and few polymorphs also. This is another portal area. Along with here also we can see the inflammatory infiltrate, along with focal interface hepatitis also in this area. The limiting plate, which first plate of hepatocytes, and there is inflammation which is spilling into them. This is another portal area. Here also we can see the inflammation. Along with that, we can see a few epithelioid cells here like these. So this is forming a non-necrotizing epithelioid cell granuloma here. However, we can see that the bile duct, which is here, is uninjured. Coming to the hepatic parenchyma also, we can see this granuloma formation here, which is well circumscribed, and there is no necrosis in this granuloma also. High power for the granuloma. There are these classical slipper-shaped epithelioid cells which constitute the granuloma. Again, here we can see that there is no necrosis associated with this granuloma. There are no organisms in it. This is a section from zone 3 of the hepatocytes. So here we can see that there is macrovesicular steatosis here, along with inflammation, which is in between the lobules and all. And here also there is inflammation together along with this nuclear glycogenization, as we can see in these foci. This together constitutes, and along with this, there is cholestasis, intracytoplasmic, and also intraductal cholestasis are there. So together, these findings constitute to steatohepatitis. Again, nuclear glycogenization here, and also cholestasis present here, along with the macrovesicular steatosis. Mason's trichrome stain shows fibrosis in the periportal areas and also in the zone 3 areas around the central vein. Here you can again see the macrovesicular steatosis. So to sum up all the findings, there is chronic hepatitis and multiple portal and lobular non-necrotizing granulomas were seen. Steatohepatitis with nuclear glycogenation was noted. There is hepatocellular as well as canalicular cholestasis and fibrosis in portal and zone 3 areas. However, there was no bridging fibrosis or nodule formation as we could see. There is no bridging happening. There are individual parts of fibrosis around the portal area and also in the zone 3. And also we could not demonstrate any acid fast bacilli or any fungi. So diagnosis of granulomatous hepatitis with steatohepatitis with the main etiologies being tuberculosis or sarcoidosis was suggested on this biopsy.
Thank you, sir. So on the basis of history, examination, the investigation and histopathology of the liver of the patient, our final differential was granulomatous hepatitis with anemia of chronic disease, etiology sarcoidosis, isolated hepatic involvement. So on the basis of this diagnosis, the patient was started on steroid the hospital on 8th August 2021 with TAP prednisolone 30 mg. Patient is being afebrile since August 2021. These are the various follow-up investigation done after starting steroid. The total bilirubin decreased to 1.12 in August and it became in normal physiological limit in November. ALP also decreased from 1268 to 99 November. Thank you. Now I would like to invite Dr. Taruna to discuss the review of literature on the topic.
Good afternoon, respected faculties and my dear colleagues. I will discuss the case that Karan has discussed in two major headings. First is sarcoidosis causing in itself a fever of unknown origin, and second is liver involvement in sarcoidosis. But before I start, I will like to introduce you to FUO. So what is fever of unknown origin? It is defined as a temperature of more than equal to 38.3 degrees Celsius on at least 2 occasions, with a duration of illness more than equal to 3 weeks in a non-immunocompromised patient who has undergone the following set of investigations as mentioned here. How do we approach a case of fever of unknown origin? After history and physical examination when the patient has underwent the following set of investigations, we look for potential diagnostic clues. If we get the diagnostic clues, we go for a guided diagnostic test, which is non-invasive, followed by an invasive. If, however, the diagnostic clues are absent, we go for whole body imaging, that is PET scan. Now, sarcoidosis in itself causing FUO is not a very common entity. When we look for the etiologies of fever of unknown origin, we see that it is basically categorized into 4 categories. First one being infection, followed by malignancy, connective tissue disorder, and the fourth one being miscellaneous. In connective tissue disorders, we see SLE is the common one, and sarcoidosis is just an uncommon etiology. This is a publication, a review article by William et al. Here we see frequencies of diagnosis within the 4 major categories of classic fever of unknown origin and conclude that infections constitute to form the major chunk of patients who present with FUO. Infections, most commonly tuberculosis, followed by neoplastic, followed by inflammatory were the etiologies of FUO, and in inflammatory also SLE was the common one. Sarcoidosis was just an uncommon etiology of FUO. And even in cases if sarcoidosis will present as FUO, these are the 3 conditions in which sarcoid will present as FUO. The first one being uveoparotid involvement, the second one where there is massive involvement of the liver by sarcoid granulomas, and the third one being neurosarcoidosis. It is said that excluding the above 3 conditions, fever in a patient with sarcoidosis should suggest an alternative diagnosis. In our patient, we did not have massive involvement of the liver as PET scan was normal. So our patient mounting fever just because of sarcoidosis was in itself a rare entity. Going to the paper which was published by our department in 2012, here 164 patients were studied for the 54 rare manifestations of sarcoidosis, and only 1 out of 164 patients, that is 0.6% of the patient, had presented as PUO. So now we have seen what is FUO. We have seen that sarcoidosis in liver presenting as FUO is not common. Now we will look towards isolated liver involvement in sarcoidosis. That is our case. Before I move on, as we all know that sarcoidosis, it is a multisystem granulomatous disorder with a bimodal age distribution. Most of the cases presenting within 20 to 50 years of age. This is another a paper from our department only, which compares multiple studies from India as well as Western. All of these studies reach to the conclusion that thoracic involvement forms the major chunk of the patients of sarcoidosis, followed by lymphadenopathy, and third one being the liver involvement. So liver involvement in sarcoidosis. Liver is the third most commonly affected organ after lungs and lymph nodes. An isolated hepatic sarcoidosis, it is considered when hepatic involvement occurs without commonly involved organs like lungs, lymph nodes, or skin. And in itself, isolated hepatic sarcoidosis is a very rare etiology. Till date, there are only 9 case reports on isolated hepatic sarcoid. Most of the patients were between 45 to 65 years of age, and patients had presented with asymptomatic elevation of ALP, to cholestasis, to cirrhosis, to portal hypertension. One patient was even misdiagnosed as hilar cholangiocarcinoma, other patient as microabscess. Few patients were misdiagnosed as hepatic metastasis also. This is a paper by Graf et al. In which 1,476 patients of sarcoidosis were studied, and only 62 patients had hepatic involvement in sarcoidosis. However, we see that there were only 6 patients who had isolated liver involvement. This was in our case also. Now we have seen that we have studied about FUO. We have looked towards the literature of sarcoidosis presenting as fever of unknown origin. We have also looked towards the case reports of isolated liver involvement. Now we will see, just in case if we get any patient of hepatic sarcoid, what will be the clinical manifestations. Patient will be aged mostly from 20 to 40 years of age, and 50 to 80% of such cases will be asymptomatic. 30% of the patients may have an abnormal liver profile, and 50% of the patients may have organomegaly on radiological examination. Only 15 to 20% of the patients will have a clinically detectable organomegaly. 15% of the patients may complain of abdominal pain. 6 to 8% of the patients with hepatic sarcoid may go on to develop cirrhosis. 3% may go on to develop portal hypertension, and liver failure is very rare. How do we diagnose sarcoidosis? According to American Thoracic Society guidelines 2020, the diagnosis of sarcoidosis relies on three major criteria. First being the compatible clinical presentation, the second being the presence of non-caseating granulomas on HPE, and the third being the exclusion of other granulomatous diseases such as tuberculosis and fungal infection. So once if a patient of whom we suspect hepatic sarcoid comes to us, we carry out the following set of investigations in which we see patient may have anemia, raised ESR, hypercalcemia may be present in 10 to 20% of the patients, and hypercalciuria may be present in 40% of the patients. Hyperbilirubinemia may be there, and there may be increased ALP and GGT in 55 to 73% of the cases. Usually these patients do not have transaminitis. Serum ACE levels and soluble interleukin 2 receptor levels may be increased. What is the soluble interleukin 2 receptor levels? It is a paper by Laura et al. Published in PLOS ONE in 2019, which studied sarcoidosis in 101 patients, and it was found that soluble interleukin 2 receptor levels was more sensitive and a specific marker for sarcoidosis than was ACE levels also. Also, ACE levels may be increased in conditions other than sarcoidosis. Example, tuberculosis, Hodgkin's disease, primary biliary cirrhosis, which are otherwise also very common differential diagnosis for granulomatous hepatitis. So we see that SLIL2R receptor levels are a major diagnostic, can be considered as a major diagnostic criteria. So once the patient has come with clinical manifestations, we have carried out the laboratory set of investigations. We go for the imaging of the patient. In imaging, hepatomegaly followed by splenomegaly is the most common manifestation, and the patient may have non-contrast enhancing nodules of variable sizes. PET scan may or may not, as in our patient, reveal a hypermetabolic foci in liver. Now coming to the histopathology. It is the most definitive diagnostics for this sarcoidosis. Characteristic morphological criteria features of sarcoidosis are the non-caseating granulomas with asteroid bodies and Schaumann bodies. How do we treat a patient of hepatic sarcoid? Once we have diagnosed based on clinical diagnostic criteria as in ATS 2020, we will proceed to the treatment of the patient. The goal of treatment is to prevent the development of portal hypertension and cirrhosis. So whom do we treat? Treatment for hepatic sarcoidosis is not indicated in patients who are asymptomatic, those who have a normal LFT, or in those who have no evidence of cholestasis. Such patients are only followed with LFT reports and liver elastography. However, if the patient is symptomatic, as in our patient was, deranged LFTs, have cholestasis, or has portal hypertension and cirrhosis, we give steroids to the patient 0.5 mg per kg per day for a period of 6 to 12 months in a tapering dose. In patients who are refractory to steroids or who are intolerant to steroids, we may give alternative agents like methotrexate, azathioprine, etc. Patients who have already developed decompensated cirrhosis, portal hypertension, or in whom there is recurrence of hepatic sarcoidosis even after treatment with steroids are indicated for liver transplant. Take home message from our cases: isolated hepatic sarcoidosis in itself is a very rare entity. Isolated hepatic sarcoidosis should be considered as a differential of FEO. And in patient with decompensated cirrhosis, after other etiology of cirrhosis has been ruled out, we should work up for sarcoidosis also. In hepatic sarcoidosis, FDG PET may be normal, as was in our case, and patients with hepatic sarcoidosis respond well with steroids. At last, I would like to thank the Department of Radiodiagnosis, Nuclear Medicine, Pathology and Gastroenterology for their worthy contribution. I call upon stage Dr. Ranveer sir for their expert opinions upon the case.
So thank you, Taruna. So this patient presented to us with history of fever, jaundice for about 2 months. So he was evaluated outside adequately, but he remained undiagnosed. So after coming to us with the available history and the examination finding and the available investigation which patient already had, we further evaluated the patient and we found the diagnosis of the isolated hepatic sarcoidosis. So in this case, the fever and jaundice, which were presented with the beginning, which obviously suggested that the pathology lies in the liver. Okay. So, but even after further investigations or like the imagings and the other biochemical investigations, we were not able to make the diagnosis till we did the liver biopsy. The reason behind the presentation of this case in today's CCR is that isolated hepatic sarcoidosis is the a rare entity, although it can present with involvement of the other organs. So that is not uncommon thing, but the isolated presentation of the hepatic sarcoidosis is rare, as we have seen. There are only few case reports. And second thing is that if the hepatic sarcoidosis presented with the so much elevated bilirubin, so there is liver involvement should be the significant. So in this significant liver involvement with sarcoidosis, we usually expect there should be some radiological abnormalities. Like particularly in the PET scan, we were expecting that there should be some metabolic uptake should be there, but this was not in this case. So with this comment, now I would like to invite the house for any comments and. Yes, sir, we had done, sir. Ultrasound was also done, sir. Yes, sir. The ultrasound was done outside. Yes, sir. Yes, sir. Sir, we did, but there was no finding. That's why any further imaging. Yes, sir. Any more comments or questions?
Do anything else to rule out an infection before you start steroids? Because infection was one of your differentials.
Yes, sir.
So would you need to do something else to rule out a fungal infection or
Yes,
something?
sir, we had done the serum galactomannan level and the urine antigen for the histoplasmosis as well. So these were negative, sir.
Those would be generally considered enough.
Yes, sir. These are the important differential for the granulomatous hepatitis. In this case, the tuberculosis is the one important differential. So Montux was the in between indeterminate, and as I already told, histoplasma was negative, and galactomannan was also negative.
Your treatments are diametrically opposite. On the one hand, you have steroids. On the other hand, you would not give steroids.
So that's why we evaluated it thoroughly, sir. So we have the set of list of investigations we have shown, sir.
Sure. So all I wanted to know was that this is generally would be enough to say that there isn't anything.
Yes, sir.
All imaging and based on the imaging, we did not get anything positive. Like PET was normal, CT was normal. And then we have done because of raised liver function, ALP was raised and bilirubin was also raised. Based on that, we have done the liver biopsy. And liver biopsy was showing there is a non-cageating granulomas. There was no cageation. Generally, in infection, we have necrosis, so there was no necrosis. Based on that, we have started the treatment for sarcoidosis. We ruled out other causes like infection like tuberculosis, which is the most common cause in our setup. And we also ruled out lymphoma also. Thank you.
Thank you.
Any other question? Okay. Thank you very much.
The next case that we are going to present is also a rare entity, though the presentation was a very common clinical presentation that we see in day-to-day clinical practice. And Dr. Joyner and Dr. Rajshekhar are going to present the case from our side. Dr. Rajshekhar.
Greetings and warm welcome everyone for this presentation on an uncommon cause of a common surgical condition by Unit 3 of Department of Surgical Disciplines. Patient under consideration is a 31-year-old lady who is a teacher by occupation and resident of Delhi. She had a recent acute abdominal event that happened a week ago, for which she was admitted in an outside hospital and was conservatively managed, and she had improved after the conservative management. However, as a part of evaluation, a CT was done and surgery was advised for the patient, for which the patient sought a second opinion and she had come to her OPD. The patient was asymptomatic when she presented to us, but on history, the patient had pain abdomen for 1 week, which was acute in onset, severe in intensity, and colic in nature, localized to the central abdomen. The pain was associated with vomiting of 2 to 3 episodes per day, which was non-projectile and non-bilious in nature, containing food particles. The pain was associated with non-passage of feces and flatus for 3 days. There was no history of abdominal distension, hematemesis, or melena. There is no history of constitutional symptoms or jaundice. The patient was admitted and managed conservatively with near-peroral nasogastric decompression, intravenous fluids, and antibiotics for 3 days, after which she has improved and started to tolerate initially liquid diet followed by semi-solid diet. On further history, the patient had a single episode of colicky abdominal pain 6 months ago, which lasted for a few hours and relieved on oral medication. However, it did not require any hospitalization and no further evaluation for the pain was done, as it was mild in intensity and short-lasting. There were no known comorbidities and no history of any prior surgeries. She is a non-smoker, non-alcoholic, and is unmarried with regular menstrual cycles. On examination, the patient was comfortable at rest and the general physical examination was unremarkable. Her pulse was 82 beats per minute and her blood pressure was 108 by 70 millimeters of mercury. On perabdominal examination, the abdomen was non-distended. There was mild tenderness in the periumbilical region, but with no guarding, no rigidity, and no rebound tenderness, and no organomegaly. The digital rectal examination and the other systemic examination were normal. So with the history and physical examination, a provisional diagnosis of partial bowel obstruction, the imaging which the patient had with her was reviewed. The patient was advised admission for further evaluation and management on the basis of imaging. Now I invite Dr. Palak from Department of Radiodiagnosis for her expert comment on the imaging. Thank you.
Good afternoon. We'll be seeing the contrast enhanced CT of the patient done outside in January 2021. So the coronal reformats. In this, we can see there is the invagination of the small bowel loop within a dilated midline small bowel loop along with the mesentery, just giving the classic bowel within bowel appearance, suggestive of intussusception. The internal herniated bowel represents the intussusceptum. However, the outer bowel is the intussuscipium. And there is associated mild mesenteric fat stranding and fluid within the abdomen, and upstream dilatation of the small bowel loops which are fluid filled. And the IC junction appears normal in this case, and the wall of the bowel is congested with thickening. However, there is no evidence of any thinning or abnormal enhancement of the wall or any pneumatosis or pneumoperitoneum. And in this case, we can see this fat attenuation lesion, which could likely be the lead point for this case, lipoma. So, concluding, this is a case of intestinal obstruction secondary to jejunal intussusception with lipoma acting as the lead point in this case, and there is no obvious signs of bowel wall ischemia in this. So the patient presented to us and an abdominal X-ray and a chest X-ray was done in our department. The chest X-ray, no evidence of no abnormal findings were seen on the chest X-ray, and there were no free air under the diaphragm. In the abdominal X-ray, however, we can see some air fluid levels in the pelvis, no dilated air-filled bowel loop seen, and the large bowel loop was extended with air. And an ultrasound abdomen and pelvis was done in our department. The images are not available for the same. However, it confirmed persistent jejunal long segment intussusception along involving the mesentery. However, no lead point was seen, and there was mild fluid in the pelvis.
So, although the patient was asymptomatic and was vitally stable, with the imaging findings suggesting an unresolved intussusception with possible vascular compromise, so a preoperative diagnosis of small bowel obstruction due to intussusception was made and the patient was advised surgery. The plan was to do a diagnostic laparoscopy and proceed based on the in-drop findings. Her preoperative blood investigations were normal, and after necessary informed written consent and arranging adequate blood and blood products, the patient was taken up for surgery. So as you can see here, an initial 12 mm camera port followed by two 5 mm working ports were inserted for diagnostic laparoscopy, and a subsequent small Panelstein incision was made. During the surgery, a bowel work was done initially, during which we found an intercepted segment of small bowel, which is approximately 100 centimeters proximal to the IC junction, as you can see in the figure A. And on attempted reduction of the interception laparoscopically, we could find a patchy area of gangrene, as you can see as highlighted in the figure B. So a decision was made to deliver the bowel out through the Finelstein incision. And as you can see in image C, that is the delivered bowel showing the unhealthy area with a focal area of gangrene. So a 45 centimeters of ileum, which included the intercepted, gangrenous and perforated segments, was resected, and a side-to-side anastomosis was performed. After securing complete hemostasis, the abdomen was closed in layers over a pelvic drain. These are the specimen photographs showing the ileum, resected ileum with unhealthy part and a focal perforation. And the postoperative course of the patient was uneventful, and she was discharged in a vitally stable condition on post-op day 4 after tolerating liquid and semi-solid diet. Now I invite upon Dr. Rahul from Department of Pathology for her expert opinion on the pathology.
So the specimen which we received on gross examination showed these multiple serosal nodules like this. Here was a nodule. So on enlarging them, these are the vague nodules we can see. So examination of sections from these nodules revealed a spindle cell tumor which was arising on the serosal aspect like this. You'll see all of them in high power soon. So this lesion was arising from the serosal aspect and going into the muscularis. This is the muscular layers of the muscularis propria here. Tumor is seen to be infiltrating these muscular layers of muscularis propria. Then it is going deep. So here is the muscularis layer, and the tumor is this these waves of hyperchromatic nuclei which you can see. It's still further infiltrating into the muscularis and reaching up to the serosa and causing an ulceration on the reaching up to the mucosa and causing an ulceration there. And this area of ulceration is seen as the ulcerations in the gross specimen. So this is the normal mucosa here, and here you can see the ulceration. So this is the full thickness section of the bowel. So the tumor is found to be transmurally infiltrating. That is, from the serosa to the mucosa, the tumor is completely infiltrating the bowel wall. On high power, the tumor is found to be composed of these spindle cells, which are very pleomorphic, arranged in a haphazard pattern with frequent mitotic figures also. So here we can see the mitotic figures here. The mitotic figure. There were many mitotic figures which we could identify in the tumor. So our differential diagnosis on this morphology and involvement was a gastrointestinal stromal tumor or a desmoplastic variant of malignant mesothelioma or a dedifferentiated liposarcoma. Sought the help of immunohistochemical markers, and we had done CD117 and DOG1 for a gastrointestinal stromal tumor, both of which were negative. Desmin was non-contributory. CD34 was also negative, which ruled out vascular neoplasms, and calretinine for malignant mesothelioma was also came out to be negative. HMP45 being negative also ruled out clear cell sarcoma, which can also present as a spindle cell neoplasm with areas of clearing, as we can see, as we saw previously. And S100 showed diffuse nuclear and cytoplasmic positivity in the tumor cells. SMA showed focal positivity, whereas MDM2 showed diffuse strong nuclear positivity. All these immunohistochemical markers point towards a liposarcoma. Along with this, the high proliferative activity of the tumor was highlighted by Ki67 labeling index, which is seen here, which came out to be around 40% in the tumor cells. So based on all these findings, low-grade dedifferentiated liposarcoma diagnosed. There was also multiple mesenteric deposits of the similar tumor, which we could identify. However, there were no lymph nodes seen after the, even though the mesenteric fat was dissected extensively.
We were surprised with the histopathology report suggesting a malignancy, and though the margins were negative, there were mesenteric deposits. So the patient was called back for review, and on medical oncology opinion was sought, and a contrast-enhanced CT of abdomen and pelvis was done as advised by the medical oncologist. Now I invite Dr. Palak for review of the radiology.
Patient underwent a follow-up contrast and CT in our department. In this section, axial section, we can see there's a fat attenuation lesion with mild thin interceptations in the ileum. However, there is no obstruction or overlying intussusception at the site of the lesion. The consequent sections, the bowel loops are not dilated and there is no fluid or any other mesenteric fat proliferation or mesenteric lesions. Concluding, in the follow-up CT, there is an ileal lipoma with no complications secondary to it.
With the concern that it was reported as a malignancy as the cause of the intersusception and an additional lesion on fresh imaging, and histopathology also suggesting mesenteric deposits, a decision was made to go ahead with diagnostic laparoscopy and resection of the new lesion. The problem of localization of lesion intraop was thought about because the bowel work which was done during the first surgery was normal, apart from the area of intersusception. So an enteroscopy was kept as a standby. And to our surprise, in the second surgery, in the diagnostic laparoscopy, we found another area of intersusception, 20 centimeter proximal to the anastomotic site and 120 centimeter proximal to the ileocecal junction. This was despite the patient being asymptomatic and the radiology showing no intersusception. So laparoscopic reduction of the intersusception was done and it showed a tumor at the lead point, as you can see now. So a 30 centimeters of ileum was resected, which included the tumor, the previous anastomotic site and the mesentery, and a hands-on side-to-side ilioileal anastomosis was done. And the postoperative course of the patient was uneventful. She was discharged on day 4 after tolerating liquid and semi-solid diet. Now I call upon Dr. Rahul for the review of histopathology.
So the second lesion which we received was entirely different from that of the from the first lesion. So here we saw this multiple lobules which was infiltrating the muscularis propria here. All these lobules were composed of mature adipocytes on high power. So and these mature adipocytes were separated by thin fibrous septa. So this was a very benign looking lesion. So composed of sheets of adipocytes with which are separated by thin fibrous septa again. Yes. So this we can compare the present lesion on the left side with the previous lesion on the right side. There are no pleomorphic benign pleomorphic malignant looking spindle cells as seen on the right side in the left side lesion. So this was and also we sought the help of IHCs this time also. So MDM2 came out to be negative in this new lesion. There were also some lymph nodes which were all of them turned out to be reactive. So there were also serosal nodules which also on examining the sections gave the same appearance. So this was a lipoma, and this diagnosis was the diagnosis of intestinal lipomatosis with liposarcoma was made on this.
So after reviewing all the histopathologies, the final diagnosis of intestinal lipomatosis with dedifferentiated liposarcoma presenting as partial bowel obstruction was made, and the patient is being followed. Patient is asymptomatic at a follow-up of 6 months and is planned for a repeat CT scan after 1 year. Now I invite upon Dr. Joyner Abraham, Senior Resident of Surgery, to carry forward the discussion.
Sending my warm greetings to everyone. We'll pass on to the discussion part of it. So intersusception is one of the rare causes of intestinal obstruction that we do see day to day in surgical practice. As such, intersusception means the telescoping of a segment of a bowel into an adjacent segment. It is usually the proximal segment of the bowel that goes into the distal segment. 95% of the time, intersusception is found in pediatric population. It is common in the age group of 3 months to 3 years, with peaking at around 4 months to 6 months. That is, the baby is planned for weaning. Usually, it can be asymptomatic or transient also, but it can also lead up to obstruction, inflammation, and possible ischemia. So you can see the most common type of intussusception is the ilio-ileal intussusception, which is followed by the ileocolic intussusception and colocolic intussusception. So the part of the bowel that goes into the distal bowel will be called as the intussusceptum, and the part that receives it will be called as the intussusceptions. So in adults, intussusceptions are even very rare, and they constitute only 1% of the total cause of bowel obstruction. Unlike in pediatric age group where we don't find the lead point usually, in adults it is usually associated with the lead point. Most of the time it is a benign lesion such as a lipoma or a fibroma or a hamartoma, but it can also be malignant. When it is malignant, usually it is a metastatic deposit, lymphoma or cyst when it is for a ilio-ileal intussusception, but it is usually primary adenocarcinoma if it is a ileocolic or a colocolic intussusception. Soft tissue sarcomas as such are very rare in small bowel, and its reports are usually limited to K series and reports. And ileal STS leading to intussusception, in English literature search, there are only 2 cases reported so far. The assets to intestinal lipomatosis. Lipomatosis is the presence of multiple lipomas in the body, and intestinal lipomatosis as such is a very rare disease, and it is characterized by infiltration of mature adipose tissue in the bowel wall. It is 90% of the time localized into the submucosa of the bowel, or 10% of the time it is usually in the subserosal plane. Usually intestinal lipomatosis is asymptomatic, but when it is larger than 2 centimeters, it can lead on to complications and can present as intussusceptions, bleedings, perforations or obstruction. On English literature search, so far we could find 17 documented cases of intestinal lipomatosis, and 4 cases so far has presented as intussusception. These are the 4 previous cases which have presented as intussusception. So all these 4 cases which have presented previously was ileocolic intussusception. 3 cases underwent a limited or a formal right hemicolectomy, and 1 of the case had to undergo a total colectomy. Or in our case, we did a lap assisted resection of the small bowel. So the chance of lipomatosis getting transformed to a liposarcoma. So far it has been believed that liposarcoma cannot arise from a benign lipomatosis. That is, liposarcoma usually has a de novo origin. But the recent pathological studies and case report have suggested that the transformation of lipoma to a liposarcoma is still possible, and it is usually occurs in recurrent cases also when the size of the lipoma is more than 6 centimeters. So Liposum Sarcomas as such, it is one of the commonest soft tissue sarcomas along with the rhabdomyosarcomas. Usually we name sarcomas on the basis of the cell of origin, and in liposarcoma it is the adipocyte, which is the progenitor cells. And according to the WHO classification, so far there are 4, they have classified the liposarcoma into 4 types, that is the well differentiated, dedifferentiated, pleomorphic and round cell, or the Mixoid Liposarcomas. Usually it occurs in the middle age or the elderly, unlike in our case in which she was a very young female. It can occur anywhere in the body, but usually it occurs in the retroperitoneum or extremities, and it is very rare usually in the small bowel. The diagnosis of a liposarcoma is usually made in the post-op histopathology by immunohistochemical examination. It is usually strongly positive for MDM2 and CDK4. In our case also it was strongly positive for MDM2, and you have to also rule out the GIST or perivascular epithelial tumors with other tumor markers, which you have done in our case. And again, primary GA liposarcomas, therefore there are total 38 documented liposarcomas that we are able to find in literature search. They have so far varied presentations like obstruction, intussusception, right iliac fossa mass, GA bleeding and perforation. So these are the 11 cases that we have found so far on literature search. As you can see, all the cases here have the age group at over 50 and around 84. And in all of these cases, they have done an open surgery. In our case, we have done a lap assisted bowel resection. And the treatment of choice or the standard of care for treating liposarcoma is complete R0 surgical resection, which we have achieved eventually in our case. And whenever we find an R1 resection in histopathology, we have to always go in for a re-resection. That is, the effectiveness of chemotherapy or radiotherapy is still unclear. There are reports of people giving radiation therapy in recurrent liposarcomas in extremities, but it is, however, not possible in small bowel. Current NCCN guidelines also don't recommend adjuvant therapy after R0 resection. And again, for dedifferentiated liposarcomas, it differs from other liposarcomas as such. It has a very high local recurrence rate of 40 to 60%, and the chance of metastasis is also 15 to 20%. And again, this chance of local recurrence is usually within the first 2 years of the primary surgery. Hence, a very close follow-up examination with imaging every 3 to 6 months is recommended for the initial 2 to 3 years, and with then annual follow-up. We are also following our case very closely. So why this case? So this case as such gave to our treating team a lot of surprises. Initially, the patient was completely asymptomatic when she presented to us, and it was the imaging which made us go in for and prompted for an emergency surgery. And again, in the surgery, we could find out a perforation, which didn't possibly cause any symptom because it was concealed in the intersection. And again, when we went in for the second surgery, patient was again completely clinically stable, and the imaging also we couldn't find the intersection. But again, when we went in, we could find an intersection. And again, in the histopathology, if the first histopathology liposarcoma was a surprise to us, again the intestinal lipomatosis was also a surprise, because both lipomatosis and liposarcoma are very rare in small bowel. And as such, whether this liposarcoma has been transformed from a lipomatosis to a liposarcoma or whether it is de novo, we might not be able to tell it very surely. The take home message: malignant lesion should always be considered as a possible source of interception even in a young adult, and intestinal lipomatosis with liposarcoma is still a possibility. And when we find a single lesion, we will have to always carefully look for multiple other lesions. This outset, I thank the Department of Radiology and everybody, and Professor Rajendra Bashit sir is coming for his expert opinion. Thank you.
On our geology and medical oncology were with us throughout this, and fine. Dr. Sameer Bakshi is the one who was coordinating with us. Dr. Deepam has come. I would like Dr. Raju and Dr.
I think this case truly highlights the famous quote of William Osler: medicine is the science of uncertainty and the art of probability. Because at every stage, there was some discordance between the clinical features and the radiology. When we saw these images, we were persuading the surgeons that you need to go in immediately, and they said the abdomen is completely silent. There are no findings at all. So although the dictum is that we treat patients and we don't treat images, but well, I think imaging has reached a point where sometimes we need to convince the surgeons based on the imaging that the patient needs surgical management. It doesn't happen very often, but occasionally we do see patients where there is such a discordance between the clinical findings and the imaging that decisions are made entirely on the basis of imaging. And pathologist, of course, is always supreme, because we said lipoma. There was, even in retrospect, when we look at the CT images, there was no reason to suspect a liposarcoma. The entire lead point was showing fatty attenuation. There were no solid areas, nothing which would make us suspect a liposarcoma. But then, of course, the pathologist found that it was a liposarcoma. Interception, as Joyner rightly pointed out, is essentially a pediatric population. We see it, because we are a tertiary care center, we see it fairly often in adults as well. In patients, in those patients, we almost always will find a lead point, which is the cause of the interception, and we look for that very carefully in imaging, and most often we do find a lead point in adult patients.
First of all, sarcomas in general are very rare tumor. Out of sarcomas are very rare tumors. Out of all 100 tumors, sarcomas comprise of 1% of all the tumors that we treat. Again, this 1% of sarcoma, there are more than 70 types. So one can imagine the diversity of the sarcomas. And when we go in details of the data for each type, it is very scarce, and trials are also very comprise of diverse population, because it is not possible to have trial for one type of sarcoma. Another issue with the sarcoma is that the same histology can occur in head and neck, it can occur in extremities, it can occur in the abdomen and thorax. So it is a very wide diversity. But as far as this case is concerned, this is a very rare case. From our perspective, what we see here that this is a low grade sarcoma. So in sarcoma in general, we classify whether it is low grade or high grade. So in a low grade sarcoma, chemotherapy doesn't work. In high grade, there is a benefit, but again, it has to be individualized decision for the case to case basis. And most important part for sarcoma, which as the senior resident has emphasized, we want it to be a R0 resection, that the tumor need to be removed. And if it is necessary, we have to sacrifice the organ as well. Because if there is a residual tumor, then the patient, we cannot cure the patient, the intent becomes palliative there itself. So it was a very wise decision to go for a relook surgery and to completely remove that. Since it was a low-grade tumor, chemotherapy would not benefit, and since the disease has been completely removed, we have planned for the subsequent follow-up. Had it been a high-grade tumor, then in this well-differentiated type of liposarcoma, which is one of the types of liposarcoma, it would have been an individualized decision. She is a 31-year-old patient. We would have probably given adjuvant chemotherapy had it been a high grade. But let us say a 70-year-old female had come with this same clinical situation, we would have omitted adjuvant therapy. So it's a case-to-case decision.
Thank you very much, Dr. Raju and Dr. Deepa. So basically, this patient, when she came to our OPD, she was practically all right, and she came with her mother, and it was a Friday, and next Saturdays we have our radio conference regular. When I saw her in OPD and when I looked at her CT, I requested Dr. Raju to review it there and then, and he was very kind enough to do that, and we had to really push her to get admitted because based on the imaging findings, because she said, I'm fine now, why do you want to admit me? And she, you know, young girl, parents are all have this concern of the marriage and surgery, cars and all that. Finally, we admitted her the same day, and then we got the ultrasound was done by Dr. Ankur. Very next day, we took her up for surgery, despite her clinical, features not being suggestive of something very acute at that point in time. The histopathology, of course, came as a big surprise to us. The biggest surprise was a second COVID, but it wasn't like 6-7 months had elapsed. It was within 2 months all this happened. First surgery, Dr. Hemang was there, and bowel walk was done. So our concern was also whether if missed in the first time, can miss it again. No, not be able to do it. So we kept a possibility of enteroscopy. Fortunately, as soon as then again we saw an interstitial suction, it was like God helped us to identify the lesion, and then a resection was. Now I would like to open for any comments and questions. Dr. C. Rajiv there. Yeah, please.
Liposarcomas tend to be more discrete, whereas lipomatosis tends to be a little more diffuse, have a larger area of involvement with a lot of it in the pelvis. How difficult or easy is it to differentiate a well-differentiated liposarcoma from lipomatosis? How easy or difficult? A well-differentiated liposarcoma versus lipomatosis.
So we vouch on the presentation. Basically, if it is a big lesion, if it is a deeper lesion, because morphologically there may not be very clear changes. I am talking about the soft tissue. So if it is a big lesion and deeply situated lesion, we always look for thick fibrous septae and look for if there is any occasional lipoblast and do MDM2 stain to identify atypical lipomatous tumor. But in this case, the problem was different because there were thick serosal nodules. We had to differentiate basically if it is just a serosal scar or serosal fibrous reaction, or it is a liposarcoma. Fortunately, MDM2 worked in this case, S100 also worked in this case, and there are lipoblasts and so many mitotic figures, so I was quite certain that this is a liposarcoma. And talking about the lipomatosis of the intestine is extremely rare, as has been highlighted, but lipomatosis has been most commonly reported in the ileocecal region. So at the terminal ileum part, so these lesions have been reported most of them have been reported. We need to keep that in mind.
So even in the hindsight of knowing that there are multiple sites involvement, not a single discrete involvement, we would still be reasonably confident in saying it's a malignancy. At the end of the day, when we have looked at it, the fact that there have been 2 surgeries, there is an extensive involvement, probably over 30 to 40 centimeters of length of bowel, multiple discrete sites, you'd still be happy saying that it's a malignancy.
Yeah.
Very interesting case, managed very well. As pointed out, discordance between radiology and clinical and operative findings. I just have 2 or 3 things. One is that retrospectively, can you look back at the previous CT and see whether that lipoma which was causing intussusception could be found, or probably it got hidden by the intussusception which is occurring now. The second thing is that in the first surgery there was no lead point seen. So if there is a no lead point and you see an intussusception in an adult, you have to be worried as to whether you are missing another lesion. And lastly, like this is the era of minimal access surgery. Minimal access is the standard of care. But in minimal access, when we talk of the so-called walking over the bowel, you just see the outer aspect of the bowel, turn it here and this side. So if this lipoma at second surgery was felt clinically with hands, could it be that like in olden times, all patients used to do exploratory laparotomy? All patients, you open the abdomen, you first see the bowel from the duodenojejunal flexure to the cecum, and then you go and see the rectum. Then you examine the liver, then you examine the spleen, and then you start your surgery. That used to be the standard. So, but nowadays what you do is that since the imaging, as Raju said, helps us so much, sometimes, as Raju has rightly said, like sometimes they tell us, they call and tell us that this patient needs surgery, and very often we have benefited from it. So maybe the imaging has changed it, but I think an exploratory laparotomy probably is much better in such circumstances, especially when you felt that there is an intussusception, but there is no lead point. So I think that was one point which I felt should be highlighted.
Thank you, sir, for this comment. Since I was in the first surgery as well as second surgery, I should make few points more clear. The lipoma was size of 2 into 2 centimeter, and the duration between first and second surgery was 3 months. So it is sure that the lipoma was also there in the first surgery. We missed that. At the time of surgery, we reduced the since it was an emergency surgery, we took up in the night time. There was definite intersusception. So we reduced the intersusception. While reducing, we also noticed that there was already perforation. So we made a small fenestral incision and bring it out. Yes, as sir said, there must be some lead point. We also had the same query at the time of surgery. But the bowel was so thickened at that time, we decided that there may be some amount of submucosal fibrosis or some submucosal element which actually act as a lead point. And that's where we stopped. And although we searched whole length of the bowel, but that was with laparoscopy, we missed a lipoma. But at that time, the idea was that there was some amount of submucosal thickening, which was actually worked as a lead point. So we decided almost 30 centimeter of small bowel. But subsequently, whether those thickening was also features of lipomatosis or something else, we don't know. But yes, we looked for a lead point, which we missed in the first surgery.
The second lipoma in retrospect on the first CT? No, we cannot. We've looked at the first CT. One drawback, of course, was that that CT was a private CT. We were looking at thick sections printed on film. And that's a huge drawback. When we look at films printed elsewhere, we are evaluating 5 mm, sometimes 10 mm sections of CT. When we look at those images on our console acquired by us, we look at 0.5 centimeter scans. So it was a small lipoma. It may have been missed at that time. It was obviously present earlier also, but we can't see it even in retrospect.
Thank you. For the benefit of undergraduate students and like first year postgraduates, like whenever there is a submucous fibrosis, intussusception usually does not occur. That's why they say that like malignancies, the adenocarcinomas which cause the fibrosis by infiltration, they rarely intercept. So it's for the benefit of the undergraduates and the postgraduates.
So Dr. Sino has made very valid points. However, we have to keep in mind, one, the surgery was done at night. You had an obvious cause of a problem which was seen. And then when through a fan and steel incision, the bowel was taken out, even physical, by hand palpation was done for a significant length of the bowel. And if we look at the second surgery, the lipoma was found within 20 centimeters of the previous resected segment. So it's possibly that the heat of the moment you find a lesion, you find the problem, you want to get it out and kind of get on with rest. But a palpation, physical palpation was also done during the first surgery because bowel had been taken out through the fan and steel incision. So despite that, it probably got missed. That is one thing, because there was a question whether it's a recurrent thing. So in our view, it is probably not a recurrent. The time period is too short between the two. So if there are any other questions or comments, otherwise we'll call it a day. Thank you very much.